I'm Dr. Rashmi Halker Singh. I'm the Deputy Editor of Headache. It's my pleasure today to be joined by Dr. Marina Romozzi from Italy, who's the first author of a recent publication entitled Pharmacological Differences and Switching Among Anti-CGRP Monoclonal Antibodies, a narrative review. Welcome. I'm so happy to speak with you about this. I think this is a really important topic. It comes up all the time.
Thank you very much for inviting me. It's a real pleasure.
So first of all, this is a topic that comes up with me and my patients all the time, talking about switching and changing amongst their medications. But I am curious, what inspired you to do this work?
Several aspects. First of all, this review aimed to summarize the available clinical data on the effectiveness and tolerability of switching between two monoclonal antibodies targeting the CGRP pathway, alongside with insights from consensus statements and international guidelines recommendation. And the state of art in this topic was really lacking of evidence because both randomized control trials and observational studies have consistently shown comparable efficacy among the four monoclonal antibodies that are available. However, the monoclonal antibodies, they differ for several key aspects, including their immunoglobulin subclass, the therapeutic target, the administration schedule, the route of administration, and also it can affect the pharmacokinetic. So,
Absolutely. They are very different, and we need more data to help sort through, how to choose between them and what to say to patients about switching and everything. So this is really helpful. So tell me about what you did.
so basically, we reviewed the literature and we found 12 articles on the topic. And we try to summarize the evidence from the results from these articles. And we found that switching from an antibody to another can offer a benefit for a proportion of patients. In particular, the response rates were ranging like for a very broad range, actually, from 10% to 60-70%. But it is really wide, but still some patients may benefit
Okay.
from that switch.
So how do you recommend that patients, when should we offer switching to a patient? Because I think that gives a lot of hope if a patient does not find one to be helpful. If you're saying that, another one might still give them benefit, what did you find from your work? When should we be recommending that switch happen?
Yeah, so actually, if the patient do not respond to the first monoclonal antibody, we can offer a second one. And so your question was actually when. So we have to consider also another aspect that is the tolerability, because of course, we spoke about the efficacy, but also tolerability, it's important. And difference in tolerability have emerged between the monoclonal antibodies targeting the CGRP receptor, so erenumab, and the other monoclonal antibodies. So in particular, patients treated with erenumab report more often constipation. So in these cases, it's pretty easy because we can consider a second antibody maybe targeting the CGRP ligand. But then the topic is much more complex when we speak about efficacy, which was your question, because we can even consider the same principle. So we can offer a switch, for example, from an antibody targeting the CGRP receptor to an antibody targeting the CGRP, the ligand itself, or vice versa. So this is a first principle. And then we can consider other aspects, like, for example, the route of administration, also the patient choice.
I think this is really exciting because even though we think about all these medications as belonging to a single class of drug, there's still so much variability between them, and they still offer so much hope to patients if one is not effective.
Absolutely, yeah.
Any other final thoughts that you want to share with our audience?
Yes, so basically switching, like we don't have a lot of clinical evidence. Also, the European Headache Federation tried to recommend something on the topic, and they really don't reach a conclusion. But they said that actually it is a viable option for patients that also maybe have failed other preventive treatment, maybe multiple preventive treatments, and for them, they are usually highly disabled and other options are limited. So in these cases, I think it's a reasonable option to offer a switch to another monoclonal antibody, maybe considering the differences that we have mentioned regarding the target, the pharmacokinetic, the tolerability, etc.
I think this is really innovative work. Thank you for publishing with us, and we look forward to more work from you and your colleagues.
Thank you very much. It was a real pleasure. Thank you.